Hello, this is Tasmia Chaudhary. So today we are actually preparing for a case for NAC OSCE station. So today's discussion topic is arm pain. So as you might already know, in NAC OSCE there are 12 stations, 2 of which are pilot stations. So you'll be scored on the rest of the 10. In each station, you'll be given 2 minutes outside to prepare for the station. So my advice on the approach you should take for the 2 minutes to prepare is you're usually given a chief complaint outside for the case. So look at the chief complaint and consider the differentials first. That way it's easier for you to go ahead, move ahead. So today's topic is arm pain. So for the differentials, uh, okay, so first consider the differentials and anything that is related to limb, any pain, the things that you consider is something related, it can be something related to the bone, like a fracture or a dislocation, or it can be something related to the tendons or muscles, like a rotator cuff tear, or if it's an aged person, then you can consider osteoarthritis, especially if it's a female, you can consider osteoporosis, and also it can be some neurological or vascular cause. You can consider here for arm pain, thoracic outlet syndrome, cervical disc herniation, brachial plexus injury, and something very important in a case of limb pain or fracture injury is to rule out abuse. You have to consider if this is a case of abuse. If usually in a case of abuse, the patient will give you hints through their demeanor, their attitude. There will be a hesitant attitude, and they will look scared. And this will help you to rule out or rule in abuse. So you have to consider that in a case of arm pain as well. So after the differentials, you go in. And what is the first thing how do you start the case? So you are given 11 minutes inside, and among them, if you have an encounter with the examiner, it will be the last 3 minutes. So the first 8 minutes, you get to talk to the patient. And if it's a combination session, that means if there's history and physical examination both, then usually it's easier to take the history first. And what I like to do, instead of breaking the whole encounter equally for history and physical examination, I like to keep 5 minutes for history and 3 minutes for physical examination. So for the history taking, the first thing that you need to do is to introduce yourself. So here's a good introduction. You can say, hello, I'm Dr. X. I'll be your physician today. Can you please confirm your name and age for me? So you will be given the name and age outside the door, but it's always, it shows a little bit professionalism to the examiner that you're confirming the name and age. Also, you can say, how may I address you? This shows a little bit empathy and it makes the patient feel involved. And then important thing, permission. You say, I'll be taking a history from you today and do necessary physical examination. If it's a combination station, then say this one as well and do a necessary physical examination. Would that be okay? In NAC OSCE cases, the patient will say, yes, that would be okay. Okay, so after introduction, we start taking the history. So you can start the history taking with an open-ended question, like, so tell me what brought you in today, or if the chief complaint is given outside, then you can also say, I understand that you're here for arm pain. So can you tell me a little bit about it? And then the patient will give a brief or detailed condition, maybe 1 minute or less. He or she or they will talk and they'll tell you about their condition. So a lot of questions will be answered through this encounter or through this conversation. But the other things that the questions that you should keep in mind that should be asked to get to a diagnosis, it's really, for me, I keep some mnemonics handy so that I can ask the questions and I don't forget uh, the important questions. So here we can see OCD. We know OCD is obsessive compulsive disorder, but here OCD is onset, course, duration. So if the patient hasn't talked about it already, then you can ask these questions like, oh, when did this problem start? And is it the same or is it getting worse? Any particular time that it hurts more? Because this is a question that will help you to rule out if there is mechanical pain, because mechanical pain will always be worse at the end of the day. So this is how the questions are working towards your diagnosis. And also, is the pain constant or on and off? How often is it happening? Okay. Then there's the pain mnemonic that you can ask. This always helps for any pain scenario, which is PQRST, the alphabets. So P is for position. Can you show me the exact location? Quality, Q. Ask, how would you describe the quality? Is it sharp pain or dull pain? Is it a stabbing pain? Is it constant? So things like that. R is for radiation. Is it shooting somewhere else other than the location that the patient is showing? S, severity. This is very important. This actually helps you to understand the patient's pain tolerance, the patient's condition, and things like that. And also, it helps in the diagnosis. So this is a very important question that you shouldn't miss. How would you rate it, the pain, on a scale of 1 to 10, 10 being the worst pain you ever had? So ask this. And T is for trigger, trauma. Also, with trigger, you can keep the pain, anything that is a relieving factor for pain. Keep all of those in mind. So anything that triggers or relieves the pain. Was there any trauma before this pain started? And now, if there is trauma history present, then I like to ask a few extra questions. I like to call them MAPLE. MAPLE, M is for medication history. A is allergy history, P is post-medical history, L is for last meal, last TT dose, if female, then last menstrual period, and E is for event. So how this question helps is because if the patient has an injury, has a trauma history, you might need to send the patient to an ER. So these questions actually help you in this situation, and it gives the examiner the idea that you are aware of your surroundings and aware of the requirements that might come ahead. So I like to ask the questions backwards, like I start from the event. I would like to ask, so what happened? Well, did you lose consciousness? Did you hurt anywhere else? Did you lose blood? Was there anyone else? Where did it happen? So you get an overall understanding of the situation where the patient was in. And then go ahead with the other questions, like the last menstrual period. We are asking this to understand if there is any chance that the female patient is pregnant. Okay. So until now, the questions that we were asking, this can be used in any pain scenario or any scenario. These are helpful for like all cases. But now we are asking some focused questions to rule out the differentials that you have in mind. For example, if you can ask if there is any neurological signs symptoms to rule out a neurological damage, like is there any numbness, weakness, or tingling sensation in your limbs? You can ask vascular signs symptoms, like have you noticed any pallor? Then rheumatological signs symptoms to rule out, like is there any restriction of movement? Is there any stiffness, pain anywhere else? Also, the question that you ask that in a particular time of the day that the pain is worse, this also helps. Then if there's an infectious cause, so ask if have you noticed any redness, have you noticed any warmth or swelling around this area? And sometimes in atypical cases like acute coronary syndrome, patient can come with arm pain instead of complaining about the chest pain. They might say that my arm hurts more. But to be a safe doctor, if you ask these questions, it proves that you're a safe doctor. So you can ask if there is any chest pain, heart racing, or sweating. Okay. And I like to ask these constitutional questions in every cases because this also gives me a good insight in the patient's condition. And sometimes it also helps in ruling out the differentials as well. So ask about fever, any recent weight or appetite change, any particular diet or recent changes. For example, osteoporosis, this can happen because of dietary deficiency. Ask about the bowel and urinary habit, any lumps or bumps in the body, any oozes or bruises in the body, warm or cold intolerance, energy level, mood. For example, this energy level and mood can help you to direct your diagnosis towards fibromyalgia if there is any problem. Because in fibromyalgia, they will complain a low energy level, a depressed mood. And if in case you find something in the mood about depression, ask other questions to rule out depression as well. Okay. And the final thing is that I like to end my encounter for the history taking with patients is a little background check. We follow the mnemonic PAM, HUGS, FOSS. So what these things are, PAM is post-medical history, allergy, medication. So if you remember, in the trauma part, for the trauma history, we also ask this question. So if once you have asked this, don't repeat them. If you haven't, then you can go ahead and ask these questions. The next is hospitalization or surgical history. You can ask about gastrointestinal or if female, then gynecological history. How the patient is sleeping. Ask about family history. Is there any condition that runs in your family? Occupation. It also helps. Sometimes there are occupational hazards that can cause problem. So ask about the occupational history. Then social history, living condition, and drug history. If the patient takes any recreational drug or tried it, if the patient smoke or drink alcohol. If the answer is yes, then you need to know how much they're drinking or how much they're smoking. And it's a good practice. In any case, if the patient says that yes, they smoke, then you can ask them, do you want to quit, or do you have any, are you thinking about quitting? So that's the social history. And finally, the sexual history, whether the patient is sexually active, what's their sexual preference or orientation, have they ever been diagnosed with any sexually transmitted disease, ever positive with HIV, if they practice safe sex. So for these questions, these are a little bit personal questions, also the alcohol and drug history. So before these questions, you can do a little bit introduction, and I say that I'm going to ask you some personal questions. Everyone who comes in here, we ask these questions to get a better view of their condition. If you're uncomfortable, you don't have to answer, but it will be easier for us or helpful for us and beneficial for you as well to answer these questions. And also, I forgot to mention this in the beginning, that giving them the confidentiality clause. So you have to tell the patient that whatever you are sharing with me or us today will be kept confidential unless required by the law, but that is rarely required. So if you haven't mentioned the confidentiality clause at the beginning, this is the time you can say it again, that we will keep everything confidential. Okay, so now the important thing about ruling out abuse. So whenever there is suspicion, I talked about it. So whenever the patient will give you some subtle hints that they are being abused, like being hesitant, demeanor, and attitude and all. So if you, it will be very clear to you actually in NAC OSCE cases if it's a case of abuse. So then you can go forward with these questions like, did you have similar injuries before? Have you ever been hospitalized for any injury like this? And you can ask a little bit direct question as well. Please don't mind me asking, but are you safe at home? Is there any chance that you are being abused? And what about the children? Is there children at home? What about them? Are they also being abused, or are they witnessing the abuse that you are facing, or are they not involved in any part? So in case, another thing that is important, in case they say yes, the children is abused as well, in that case, you have a duty to contact the Child Protection Service. So you have to mention that as well. I'm sorry, but I have to contact the Child Protection Service for this. Okay. And also the other questions like, does your partner or abuser have access to any kind of weapon? Have they ever used it on you or threatened you? Do they have a drinking problem or an addiction or anger management issues? Who else knows about the condition that's going on? Do you have access to any financial resources? Do you have access to any communication device or transportation? Do you have an escape plan in case things get worse? And usually in an abuse case, you might be given some counseling. You will be required to counsel the patient. So you will talk about giving social worker, connecting the patient to a social worker, information about help and what to do for maybe rehabilitation if they need a home or shelter. Then talk about those and plan an escape, that if things get really worse, call 911 or get out of the home with your children, things like that. And as I mentioned, you have to talk about Child Protection Service if the children are involved. Okay, now the physical examination. If this is a combination session, then you will have to do a physical examination. And I know I say that I would prefer 3 minutes for physical examination, and it might sound very hard, but it's doable. So if you practice a few times, then it gets easier and it comes easily. So before starting the physical examination, anytime you're touching the patient, you have to take permission. So You say, now I would like to perform a physical examination to better understand your problem. I will look, feel, tap, and listen as required. If at any point you feel uncomfortable, please let me know. I will stop at once. Okay, so you're checking the understanding of the patient. And then this patient says, yes, okay. So, okay, then may I proceed? Yes, now you start. So for any musculoskeletal examination, you have to check the look, feel, move steps. So for look, you are doing an inspection of, and if there is pain in one limb or one extremity, we check both to compare. So you will be checking both extremities for SIDS. That's another mnemonic. SIDS, swelling, erythema, redness, any atrophy of the muscle, any deformity, and scar. And if you have enough time, sometimes the stations are just physical examination. So you get the whole 8 minutes for physical examination. For that, you can also move to the shoulder and check around the shoulder area as well, and also check the joints and the fingers, the hands, everything. So as much as you can fit in your time. It depends. It all depends on the time. So if it's 3 minutes, like a combination station, then you are not actually expected to do so much. Just focus on the arm and the joint is around. But if it's a full physical examination station, then you have to go a little bit beyond that. So after look, it comes to feel, TTC. TTC is temperature, tenderness, and joint crepitations. And every time you're doing a physical examination, you actually have to narrate it to the examiner. You have to say that now I am doing the inspection of both arms, or inspection of doing the left arm and right arm, and I'm seeing no swelling, no erythema, no atrophy, no deformity or scar. Now I'm checking the temperature. Temperature feels normal. There's some tenderness, no joint crepitations. So like that, you have to narrate the procedure you're doing, and then move. You have to check the muscle tone, muscle power, any active versus passive movement. And another tips for short time shortage, if the active movement is present, then you don't need to actually check the passive movement when there's shortage of time. So you can skip the passive movement checking. And also the range of movements. If every movement is, if you can do all the like flexion, extension, abduction, adduction, and all those. So, and rotations. So check those. And you can perform some spatial tests. So I have wrote a lot of spatial tests here, like painful arc, anti-can test, belly press test. You don't have to do all of them all the time. It depends on the patient's symptoms. So if you feel like it's something, for example, if you feel like it's something about, it's from an impingement. So these 3 tests, Neer's test, Hawkins test, Hornblower's test, etc., these are done for checking the impingement. So you can just do these 3 tests and be done with it. So it all depends on how much time you have and how fast you can do them. So, and always finish the musculoskeletal system with sensory, reflexes, and pulses. Sensory means the dermatums. Also, you can check the position, vibration. It depends on your time again. And then the reflexes of the specific limb, and finish with checking all the pulses of the area. So that's the end. So after that, if sometimes you might have the encounter with an examiner. So they will ask you questions about, well, maybe what is your diagnosis, or what is your management plans, and things like that. So that's that. And then, yes, finished. You're out of the station and you're moving ahead to the next one. This was the end. That will be for all for today, and all the best for your exam.